Welcome to ABC tutorial. Today we'll talk about shock. Shock is a life-threatening condition where enough oxygen does not reach the cells and causes problems with metabolism. It can be reversible at first, but if not treated quickly, it can become irreversible, leading to multi-organ failure and death. Shock may result from a variety of physiological mechanisms, including sudden reductions in the total blood volume through hemorrhage, sudden reductions in cardiac output as in myocardial infarction, and widespread dilation of blood vessels as in some form of infection. Whatever the central physiological mechanism, the effect of shock is reduction in blood flow and delivery of oxygen to the cells. There are mainly 4 broad categories of shock, which are distributive shock, hypovolemic shock, cardiogenic shock, and obstructive shock. Distributive shock is characterized by peripheral vasodilation, resulting in pulling of blood to the veins, thus reducing the amount of blood and oxygen getting to the tissues. Distributive shock can be classified based on the mediator of the systemic vasodilation. Types of distributive shock include septic shock, anaphylactic shock, neurogenic shock, and endocrine shock. Septic shock is a complication of sepsis with severe circulatory, cellular, and metabolic abnormalities resulting in tissue hypoperfusion. The systemic vasodilation is mediated by bacterial cell wall and endotoxins. The most common pathogens associated with septic shock are gram-positive bacteria, including Streptococcus pneumoniae and Enterococcus. Anaphylactic shock is a clinical syndrome of severe hypersensitivity reaction mediated by hemoglobin E, resulting in cardiovascular collapse and respiratory distress. The immediate hypersensitivity reactions can occur within seconds to minutes after exposure to allergens such as drugs, food substances such as peanuts, insect stings, and latex. Neurogenic shock can occur in the setting of trauma to the spinal cord or the brain. The underlying mechanism is the disruption of the autonomic pathway resulting in decreased vascular resistance. Endocrine shock is due to underlying endocrine etiology such as Addisonian crisis and myxedema. Hypovolemic shock is characterized by decreased total blood volume. In the early stages of hypovolemic shock, there is increased vascular resistance, which is a compensatory reaction to the depleted blood volume. This compensatory reaction is mediated by sympathetic overdrive. In the later stages of hypovolemic shock, cardiac output also decreases due to depleted blood volume and manifests as hypotension. Hypovolemic shock can be divided into 2 broad subtypes, hemorrhagic and non-hemorrhagic. Common causes of hemorrhagic hypovolemic shock include traumatic injury, gastrointestinal bleed such as variceal bleeding, blood vessel diseases such as ruptured abdominal aortic aneurysm, and spontaneous bleeding in the setting of anticoagulant overdose. Common causes of non-hemorrhagic hypovolemic shock include gastrointestinal losses such as massive vomiting and diarrhea, skin losses such as in burns, Stevens-Johnson syndrome and toxic epidermal necrolysis, and interspace loss in which there is abnormal accumulation of fluid in body tissues rather than in the intravascular space, mostly in the interstitial compartment, such as in pancreatitis, liver cirrhosis, and intestinal obstruction. Cardiogenic shock occurs when there is decreased cardiac output as a result of heart diseases leading to systemic hypoperfusion. Common causes of cardiogenic shock include myocardial infarction, cardiomyopathies, cardiac arrest, arrhythmias, and valvular disease. Obstructive shock is due to extracardiac causes leading to a decrease in cardiac output. It is due to obstruction in the outflow of blood from the heart or obstruction in the filling of heart with blood. Causes include increase in the resistance of pulmonary circulation, such as in pulmonary embolism and severe pulmonary hypertension. It could also be due to impaired filling of the right heart or decreased venous return to the right heart, such as in tension pneumothorax, pericardial tamponade, and constrictive pericarditis. The fundamental defect in shock is reduced perfusion of tissues. Once perfusion declines and oxygen delivery to cells is inadequate for aerobic metabolism, cells shift to anaerobic metabolism with increased production of carbon dioxide and elevated blood lactate levels leading to acidosis. Cellular function declines, and if shock persists, irreversible cell damage occurs and death. During shock, both the inflammatory and clotting cascade may be triggered in areas of hypoperfusion, leading to vasodilation and pooling of blood, leading to relative hypovolemia, which further worsens the tissue perfusion. Thus, at the later stage of shock, this acts as a vicious cycle leading to worsening of the patient's condition. The common signs and symptoms of shock include altered mental status such as lethargy, confusion, and somnolence, The hands and feet are pale, cool, clammy, and often cyanotic. Capillary filling time is prolonged. Excessive sweating may occur as a result of sympathetic system activation. Peripheral pulses are weak and rapid. There is tachypnea and hyperventilation. Blood pressure tends to be low, with systolic blood pressure usually less than 90 mm of mercury or unobtainable. There is also reduction in urine output. Distributive shock causes similar symptoms except that the skin may appear warm or flushed, especially during sepsis. The pulse may be bounding rather than weak, and in septic shock, fever, possibly preceded by chills, is typically present. Some patients with anaphylactic shock also have urticaria or wheezing. Other symptoms of the underlying etiology, such as chest pain in MI, may be present. The diagnosis of shock is mostly clinical, based on clinical evidence of insufficient tissue perfusion, such as depressed level of consciousness, oliguria, and peripheral cyanosis, and also signs of compensatory mechanisms such as tachycardia, tachypnea, and diaphoresis. Specific criteria include altered mental status, tachycardia, that is heartbeat greater than 100 beats per minute, tachypnea or respiratory rate greater than 22 breaths per minute, and hypotension of systolic blood pressure less than 90 mm mercury or a 30 mm of mercury fall in baseline blood pressure. Oliguria with urine output usually less than 0.5 ml per kilogram per hour. Laboratory findings that support the diagnosis include serum lactate levels greater than 3 mmol per liter, base deficit of less than 4 ml equivalents per liter, and PaCO2 of less than 32 mm of mercury. However, none of these findings alone is diagnostic, and each is evaluated by strength, that is worsening or improving. Shock is usually fatal if left untreated. Prognosis depends on the cause, pre-existing illness, time between onset and diagnosis, and promptness and adequacy of therapy. Shock is a medical emergency and must be managed promptly. First aid involves keeping the patient warm. External hemorrhage should be controlled. Airway and ventilation should be checked and respiratory assistance given if necessary. Supplemental oxygen by face mask is provided. And if ventilation is inadequate, airway intubation with mechanical ventilation may be necessary. IV access is secured. Typically, a fluid challenge is given, that is, 1 liter of normal saline is usually infused over 15 minutes. In hemorrhage, Ringer's lactate is commonly used, although use of crystalloid should be minimized in favor of transfusion of blood products in major hemorrhage. Unless clinical parameters return to normal, the infusion of fluid is usually repeated. However, fluid challenge should be done carefully in patients with signs of pulmonary edema. After the initial resuscitation, specific treatment is directed at the underlying condition. Additional supportive care is guided by the type of shock, such as surgical control of bleeding and transfusion for hemorrhagic shock and epinephrine for anaphylaxis. Patients in shock are critically ill and should be admitted into the intensive care unit for continuous monitoring.